this tracing can be a little tricky for some people because you've got this high frequency, low amplitude deflections going on here that kind of looks like atrial fibrillation. One clue that this is probably not atrial fibrillation is that it's pretty regular. And AFib can look regular when it's going fast, but when it's going slow, it tends to be irregular enough that you can see it pretty readily. But let's start at the beginning with the rate. So we're 300, 150, 100, 75, 60, 50. So our heart rate is somewhere in the 50s. And then let's look at our rhythm strips. Hard to see any distinct P waves here in V1, but if you look down here in V2, particularly over here on the second part, the second half of the tracing, that looks like a P wave, that looks like a P wave, that looks like a P wave, so does that, that, and that. The first couple here don't really look like it. But once you've seen that interval there and you go back and look, you say, okay, that could be a P wave, or that, or that. So it is sinus rhythm, sinus Brady specifically. Axis looks like it's up in 1, probably a little bit down in F, and then 2 is really right at isoelectric. It's got the same amount above and the same amount of below. So if it's isoelectric, remember it's perpendicular to the vector of that lead. Lead 2 is at 60 degrees. So that means this must be at minus 30, so that's right at the cutoff of left axis. So you can call this borderline left axis if you want to. Probably wouldn't make too much of it. Intervals here. So looking at our P wave again, our PR interval does appear to be prolonged. Here's a P wave that starts right on a big box, so that would be 200 here. So we're talking about a PR that's probably at least about 300. The QRS also appears to be wide. Depends on which lead you look at. If you look here in AVR, you may think that that looks relatively narrow. You may think that 1 looks narrow, except that that is also part of the QRS right there. And so look over here in some of the precordial leads and you can see that it's wide. It's greater than 120 milliseconds. It's more than 3 small boxes. So is this right bundle, left bundle, or a non-specific interventricular conduction delay? In V1, remember that V1 is a right-sided lead, second right intercostal space up here. So anything going towards V1 is upright in V1. It's headed towards the right side of the heart. The right bundle, if it's blocked, is going to cause the right side to depolarize late. So you're going to have a right-sided signal at the end of your QRS. And that's what we see here with a tall R wave in V1. V6 is at the apex in the midclavicular line. This is a left-sided lead. Everything should be up in V6. Anything down in V6 is going back towards the right side of the heart. What do we see here in V6? We see an S wave, negative deflection into the QRS. So at the end of ventricular depolarization, something's heading towards the right. That means that the right bundle is blocked. So that's what this is, right bundle branch block. QT interval, it's definitely less than half the R to R. It is a little prolonged if you just measure the number. It's not bad, but 400, 480. But the heart rate is very slow. When you correct that for the rate, it should be just fine. Ischemic changes, not really seeing much. T waves are going the same direction as the QRSs, don't really see any ST shifts. So I don't have anything to be concerned about there. So I think really the summary of things then is sinus bradycardia with first degree AV block and right bundle branch block.